Welcome to your most favorite channel, Heartbeat. My name is Dr. Amrit Kejriwal. As a student, I say most of the teaching will be digitalized. Hard copies of books will become obsolete. They will be replaced by soft copies. Lectures and lecture halls will cease to exist. They will be substituted by videos and online classes. Practical classes will remain in medical sciences. We have to prepare ourselves for a revolution in learning and teaching methods in all disciplines. Today we learn something about respiratory alkalosis. Channel's name is Heartbeat. My name is Dr. Amrit Kejriwal. Pathology. There is alveolar hyperventilation, which decreases the PaCO2, and decrease in PaCO2 causes the pH to increase, and the buffers consume the bicarb. It is commonly seen with mechanical ventilation and critically ill patients. Respiratory alkalosis. During the range of PaSO2 between 40 to 15 millimeters of mercury, it is directly proportional to the bicarb. The bicarb adjusts itself to the PaCO2. Hypocapnia greater than 2 to 6 hours has to be present for respiratory alkalosis to develop, and decrease in renal ammonium excretion occurs, and there is a reduction in filtered bicarb deabsorption. There are various etiologies: pain, anxiety, fever, cerebrovascular accident, meningitis, encephalitis, tumor, trauma, and also there are various causes of hypoxemia which can cause respiratory alkalosis, such as high altitude, pneumonia, pulmonary edema, aspiration, severe anemia. Miscellaneous causes also, such as septicemia, hepatic failure, mechanical hyperventilation, heat exposure, and recovery from metabolic acidosis. Compensation in acute respiratory alkalosis is completed within 5 to 10 minutes of onset of hypocapnia, mainly due to non-bicarbonate buffers are involved, and the bicarb falls by approximately 2 milliequivalent for each 10 millimeter mercury fall of PaCO2. In chronic respiratory alkalosis, it is completed in 2 to 3 days of onset of hypocapnia. There is a transient decrease in net urinary acid secretion, persistent decrease in bicarb reabsorption, and bicarb falls by 4 milliequivalent for each 10 millimeter of mercury in fall of PaCO2. Respiratory alkalosis. So, there is an increase in pH greater than 7.45, and pH is equal to 6.1 plus log bicarb by 0.0301 by PCO2. So, if the PCO2 decreases, to maintain the pH, the bicarb decreases correspondingly, but pH may still be normal in coexisting acid-base disorders. So, if PCO2 is decreased, check the bicarb. In acute cases, the bicarb should decrease by 0.2 millimoles liters per mercury per decrease of PCO2, and in chronic cases, bicarb should decrease by 0.4 millimoles liters per millimeter decrease of PCO2. If not, another disorder exists. Associations. Acute hypocapnia may be associated with decrease in potassium, decrease in phosphate, and decrease in free calcium, and the symptoms of respiratory alkalosis are related to that of hypocalcemia. Clinical features. Primarily of the underlying disorder, patient may have dizziness, mental confusion, seizures, ventilated patients may have there, and cardiac output and blood pressure may fall. Again, the patient may have paresthesias, chest discomfort, or circumoral numbness. Treatment. Correct the underlying disorder. Treat only if pH is greater than 7.5. Slow correction in chronic respiratory alkalosis is warranted to prevent metabolic acidosis. Mechanically ventilated patients require change of ventilator settings. Thank you all.